Hey, everybody. Welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. I'm going to do it opposite way this time. I'm tired of going this way around. So we've been recording all day long. We're tired. On that side of the table, it seems like he always gets the last introduction, so we're going to do him first this time. We got a Ray Pace over there. I got a Dr. John Hill here to my right. And we got Caleb Ferroni here to my left.
Last but not least, of course.
Today, last but not least, but in no particular order. But so today we've got a kind of a grab bag of leftover questions and comments that we wanted to work through. So we had intended to get through these in some extra episodes, but really there's enough here to kind of become its own episode. So this is stuff that's either come off of the comments off Facebook or YouTube, and subsequently these are things that have been put in at prehospitalparadigm.com. There is a link under podcast for Ask a Podcast Question, and I'll say that 9 times fast. And that comes directly to us, right? And that can be anonymous, or you can put your
name there if you want.
You don't have to. As a matter of fact, all of these. Well, I don't know that it really matters because we have them in anonymous format here, even if you put your name. So regardless, that's where these first pool of questions come from. So let's get into the grab bag and start with the first one. And the first is: do you see RSI becoming a standard in the EMS protocols? And I think that's. I think that question is really, do we anticipate it becoming standard of care? Because it is already standard, right? Mm-hmm. Yeah. There is an RSI protocol, but not every department participates in it. And so is it likely to become standard of care? So you guys want to chime in? I don't believe we're headed there. And I'll bolster that conversation here in just a minute, but I don't see it becoming the standard of care as you didn't do RSI, you're somehow in a non-compliant state. But
I think I don't think it's going to become a standard of care. I think there's the option in our system, and then we also have given an option to non-RSI departments in the protocol.
Absolutely.
So yes and no, I guess, would be the best question. I don't think RSI is right for every agency. That's my personal opinion. I think there needs to be a certain set of competencies there. You need to have a high percentage of intubation success rates. I think there's some other layers there versus everybody's just going to get it. Everybody's just going to get the drugs. I mean, this is a high risk procedure where you are paralyzing that patient. You're taking their ability to breathe away. Correct. So if you cannot successfully intubate or have the proper tools, training, ongoing training, with already a good base foundation, I don't think it's right for your organization. I'm not saying anything negative towards anybody's organization, but it's not right for everyone. It takes a lot of buy-in from the organization, the members of that organization, the medical director,
the financial component.
Yeah, there's a financial component of it too.
Yeah.
So I mean, as an organization, you got to think, hey, if I'm going to commit to this, then I already, in my personal opinion, I would want a high success rate of innovation now, oral trachea innovation, and we have video laryngoscopes as well.
Yep.
I want to see that at a high functioning level now before I'd even consider this, and then I have to commit to the financial piece of sending all of our people to training. We have to engage the medical director. They obviously would have to approve of that. And then it's ongoing QA, ongoing training, ongoing competencies. So it's something you have to maintain. So it's a lot of work on the entity's end, the provider's end, and that might not fit every organization.
Well, I think to build on what you're saying, I mean, UH covers a vast area. And some of those departments that are within the protocol can't RSI yet, and that's not a bash against them. It's just they might be a volunteer department where they only have one medic on staff, maybe, and according to the protocol, and not just our protocol, but the state, you have to have 2 RSI certified paramedics on the squad. You have to have a lot of training, like you said. I mean, quarterly intubations with either high fidelity or live intubation. Yeah. And that alone, I mean, there's some departments where you will never get 2 paramedics in a squad together. So it's not in the realm of possibility to go everywhere just yet.
Yeah, you were talking about the shoulds, but there's is, to your point, a bunch of musts.
Oh, yeah.
And that's why my department, we don't RSI simply because we can't, on a daily basis, can we have a few one-off cases? Sure. But can we satisfy all the musts on a regular? No, we can't. And it makes no sense to invest the time, invest the money for a potential one-off, right? So that's our election not to.
Think
Our
going back to when we
drug
sort of
assisted-
started certifying local departments in RSI, since then, and that's been a while ago now, it was 6 months ago or so, there's only been one RSI performed since then. The rest of the time, the ketamine alone was enough.
No, that was where I'm going, right?
So, out of all of the departments that I've helped train to get there, to only have one, which I think is an adequate number, I think that's realistic, that one has been RSI'd since then.
Sure.
Out of multiple departments, I think that speaks volumes. Is it really something we need? It's another tool in the toolbox. And if you're able and you're have the equipment and the training and the money to do so, why not have that? It's just like having an extra tool in the fire engine.
Yeah, and I don't want to be misunderstood. I'm very pro innovation. I believe that's the golden standard. That's what we should do. I teach that way. I believe in that. Our organization does. We want high success rates with innovation. But there's a lot of musts, shoulds, shalls. We get
Correct.
There's all those components you have to have. So by no means would I steer any agency away from it or working towards it. I'm very pro innovation, along with our organization. But just like you were going to say, we have been successful with the ketamine and I've personally been on one of those runs where it worked. It was very successful. It's what the patient needed. We had no issues. First two pass, or two pass on the first try.
Success,
yeah. I mean, it's just, I think that gives us another outlet. So you have to weigh those. Like, do we really need to do this? Do I have a higher suspicion that our organization needs it or not? Maybe transport time could weigh into it. I don't know.
I'm with you. In my time as medical director, I've only had one case that I've heard about and or reviewed that it probably would have been required. But then again, kind of talking back, we talked off camera about like blood products on ambulances. Like you have an answer to that question. If you have an airway that you guys can't intubate and otherwise and need help on scene, there's ways to get around that, right? You call for a helicopter, they have those drugs, they have that portion of the protocol if you need that help on the scene. But lots of times you can bag through it. You can put an oral airway in. I mean, you have all these adjuncts that you can do. They don't necessarily need to be intubated. And I talk about this when I'm talking about airway management. You're gonna set up. You're gonna get ready to intubate them, and your failback's going to be, I'm gonna have a bougie available, or I'm gonna put a bougie in my first try to get that tube in, and then I'm gonna have my supraglottic available. And the absolute failback is a crike if I absolutely need to.
Cut to air, right?
Yep. But there's lots of times you can bag through it. You put an oral airway and you can just bag them and get them to the hospital.
Absolutely.
And then when you bring them to the hospital, you guys have 2-3 guys or gals on the squad coming into us, and you've got a room full of more resources.
And I think you're hitting on our next point here, which is what is the most important things a medic can do to prepare for field RSI.
Prepare to fail.
Yeah. Prepare to fail, and remember your first attempt's your best attempts.
Yep.
And the one thing I butted heads a little bit with early in my career, and now I totally understand, is a particular person from AirMed will tell you that the least experienced person should be your first to intubate, because how else is that person going to get experience? And if you keep falling back on the people who already have the experience, someday they're not going to be there. So I agree with that too, but just make sure that a lot of your I think preparing for this starts and training. And you've done this 1,000 times in training.
Yeah.
You can do it with your eyes closed, but you wouldn't. And your equipment's all ready, and you practice like you preach. You don't just start with the tube. No, you start with the setup, and you start with the protocols, and then you go and move on. And understanding that oxygen's a huge part of this, and you're electing to take somebody's airway, so be prepared to do it.
Yep.
And oxygenating prior is huge.
Previously, you had made the comment, which I think holds true, and I think it's we're going to take this airway on our time. Right?
Yeah.
This is not a hurry-up procedure. This is not something that's if you're rushing it, it probably
not RSI.
it should not be it should not be done. Which rapid is in the
Rapid's in the name, but the rapid is in there.
It's
for
more
the-
induction.
How quickly I'm going to induce the patient and paralyze the
sequence
patient.
of the sequence of the
the
agents.
drug,
Yep.
yes.
Yep. Not hurry up and jam
do
a tube.
this.
Yeah.
No, yeah.
Right. And the nomenclature probably leads to some misunderstanding
And
of that.
there's suggestions out there that to rename it medication assisted airway management, instead
Which I
of
think is
rapid
better
sequence
anyways.
inhalation.
It's
Yeah.
just, you get the hastiness out of it because, I mean, you want to be hasty, don't get me wrong, but to get there shouldn't be hasty. To get there should be a solid checklist, which we have and you must follow, of, getting all your equipment together, performing your Malvin patty. And again, like I think we said before, if this is the first time you're hearing that word, you're not RSI ready.
Right.
You're doing your lemon numerics, looking at your 332s, looking at your Malvin patty score, looking at your equipment. It's a lot to do, and that's not going to happen like this.
How long does a experienced provider take to do all that?
Not
Seconds?
long. Not long.
Yeah. I mean, your checklist is one thing, right? But sizing up your patient and seeing what size tube am I going to use, what size blade am I going to use, what type of blade am I going to use.
That should be pretty quick.
Instantaneously, I can tell you exactly what I want.
Yes.
I actually just recently had my last patient I had came in respiratory distress, put her on BiPAP. She failed BiPAP. She got worse after an hour on it, and we elected to intubate her. And I had a medic who works in the institute, but she went through paramedic school during COVID, and she has 0 live intubations. I got her first. It's my 2000th intubation. It's going to be her first. Very organized, very all set up. I mean, this is a patient who had been in my care for over an hour. We had her on BiPAP. Failed it, but we weren't rushing to her side to we're going to do this. We called respiratory. Everyone was in the room. We did our timeout. We had everything set up. We had all of our equipment. I taught her the way that I like to do intubations, and I do all of my intubations with the head up. And we went in there. She did it. She got it first time. She's like, "Oh, that was really easy." I'm like, "We were set up to do it."
Right.
And I was right. I was right there. Again, I'm the experienced operator in this case. I can supervise her. I know she's doing what she's doing. Oh, you need to go a little bit deeper. There's your view. Okay, now put your tube in. There you go. There's your first one.
Yeah.
Easy peasy.
And
to
I'm
that
sure
point,
the patient was oxygenated well before this and had
100%
reserves.
on BiPAP, and you can do your apneic oxygenation, all that stuff. Yeah. And we did exactly what the protocol called for because she was a paramedic. I'm like, what does our protocol say? It says rock and ketamine. I'm like, well, that's what we're going to use then because that's what you're going to use in the field.
And in all honesty, if you're RSI in a patient, it should be one of the easiest intubations you've ever performed. It should be the most relaxed intubation. And if you go in there and you're fighting the patient, just wait. Wait. You need to wait a little longer. They're not ready.
Well, and I think I told Scott this story is that because she was hypercarbic and getting worse, we had turned up the BiPAP to backup rate to hyperventilator.
Yeah,
And so I'm used to patients being, if they're on BiPAP, we're going to intubate them. Their backup rate's going to be set to 12 or something. So we push the medications, and I'm waiting for her to stop breathing and have it kick in. But I forgot we had the backup rate set to 25, and so she kept like, "Wow, she's really breathing a lot." And then my trick for checking paralysis is I hit their eyelashes because they should blink, and she didn't. I'm like, "Oh, we have a backup rate. We're doing this. She's out. We can continue."
I think along the lines with that too is we've talked about a checklist. Preparation is key. Lay out everything to success.
Set up.
And I really think if you're an organization out there that wants to do a RSI, because I'm very pro innovation, and our organization's having this conversation right now, I think if you take a very structured approach to it, if we want to get to this, then maybe I want to see our innovation success rate at 75 or 80% first. Right. And then,
that would be my recommendation.
If you're not there, then we need to increase the training, with high fidelity mannequins, frequency of intubations. And then it's not always just intubating on that hospital bed. How about we put the patient on the floor and then we actually get on the floor because it's where we intubate people, not on the table. Like when we take ACLS class, it's like, yeah, they're on the table. You do that, you tube the dummy and you move on. So maybe move that to put the mannequin between two beds or something. You know what I mean? We need to try to increase that situation to be more realistic and then continue that on. And then I think you will gain the increased innovation success rate out in the field, whether that's through using a regular laryngoscope, or maybe you're incorporating a video laryngoscope now, incorporating your bougie, and get your success rate up. And I think if you set a path for your organization and work with your medical director on it, it's agreed upon. I think most organizations could get there just fine, you know, and it might be based on personnel and stuff like you mentioned, Caleb, but I think if you're looking at doing that, I think you really need to just lay out a plan for your organization. So,
But I think it's going to be a full-time organization, right? It's a full-time professional medic that's going to be doing it.
Right.
oh yeah,
Not necessarily a part-time crew or half volunteer or
right.
you're the basic crew. In some of my counties I cover, there's a few paramedics and they'd run intercept. Those aren't going to be the patients or people we can do RSI for.
Yeah, there really might just not be a need for it. I mean,
Correct.
yeah,
And they
there might
even
not.
even that entire organization still, like much like mine, I'm not going to have the staffing on any given day, right?
Yeah.
I'm not going to put
100%.
right?
And you're not a
It's
small shop.
I'm not a small shop at all. I mean, we're talking 60K, 60,000 calls a year. I still have a medic and a paramedic, paramedic and EMT on most calls, right? The medic pairing doesn't even get you there to begin with because you need a third person, right? Because it mandates 3 providers, at least 2 of which are RSI trained paramedics. The video laryngoscopy is a required thing, and there's all these other things baked in. I do want to you said this should be the easiest intubation. That's assuming regular or not compromised upper airway anatomy, right?
Oh, sure,
If
sure.
if
If we're RSIing because of a massive burn or something, that might be a little different.
Well, I just wanted to make the point that drugs don't fix stupid airway anatomy, right? So if they're already a Malampati 4 before you start, that's not going to make it better, right?
Or if they're just abnormal from, let's say, a very anterior airway.
Anterior airway.
don't know that
they've got
until you're-
horrible kyphosis
Yep,
or
and-
something like that, right?
Yeah.
Yeah, this doesn't fix all problems.
But I actually have to go back to a point where, yeah, if I have someone with me that has less experience and I want to get them experience, I'm going to pick which patients they intubate.
Absolutely.
The patient that's got a burned face, that's going to be my tube. Absolutely. I'm not going to train someone on a difficult airway. I'm going to train them on the typical airway.
Crawl, walk, run.
Yep. And once you're proficient and an excellent management of a typical airway, then I'm going to start giving you more difficult airways. But
That sets you up for success, though, going forward. If my first attempt was on the worst airway of your life,
Yeah.
that's what I'm going to think is normal, and it's
Correct.
not going to help me out at all.
yes,
Also, no.
No, it doesn't build your confidence,
No.
and then you might avoid doing it, and
Patients
stuff like
that
that.
actually need it. Yep.
Correct.
Yeah,
Yeah,
that's
could be just bad.
agreed. All right. Anything else on RSI? So we got those.
No, we're kind of talking about that
Standard.
in our organization right now. Should we do it? Should we not do it? Or, what do we think?
But and the question goes back, and you need to look back at over the last year or 2 years or 3 years or this set amount of patients. How many times would I have thought RSI would have been beneficial? And if that number is approaching 0 or 0, you don't need it.
Yeah.
Right?
No, that's good. It's a good way to put it.
Correct.
And the other option in the protocol has worked for us too. So it's like,
Yeah, you still
we have the tools, we have the musts. We could produce the 2 paramedics and,
Yep,
and 3
yep,
crew members,
absolutely.
and we have the video laryngoscope,
yep.
and we have all that stuff. And I think our providers at our organization do a really good job. They train well, they prepare well for it, and we've kind of just used the protocol part of it. And we've had good success with that so far. So it's like, I go back to is there the need?
there
right?
really a need? Yeah.
Yeah.
And the only one that comes to mind for mine was just terrible trismus, and they were like lockjaw. Like they could not get into the airway. That was the one time
understandable.
where you need the paralytic. But at the same time, if you can pass a nasal airway and you can bag through them, that's what you do. And then on that case, I might, depending upon what exactly is going on in that patient, I might give them a paralytic, and I still can't get into their airway, and I have to then nasally intubate them, and then I've got the tools for that. So
I miss nasally intubating.
Now,
I can feel it. push it in.
This next question I really like.
Yeah,
I really
no,
do like this. When would you use different analgesics? Toradol, fentanyl, Dilaudid, ketamine.
So this I like this question too, right? And I think before we dive into this, we should broad brushstroke over this entire thing. Is you could probably ask 10 different people
And get 10 different answers.
and get 11 different answers, right? So there's a lot of subjectivity to this, and you and I were talking. There's a lot of nuance, right?
There's a lot of nuance in this.
And when I read that, and I read it, and I pondered it over the weekend, and I forced myself to. I know which agents I would use and for what reason, but I never really in one bolus tried to tell anybody here's my thought process on it, right? So I actually took a minute and made myself a little flow chart of how Scott thinks about these things. Again, I'm not saying this is right, and we're gonna go.
Yes. No.
Absolutely not. No.
Have they walked? Have they tried? Have they tried today?
But again, this is just my practice with my comfort level with the analgesics that I have available, right, in my kit, right. So my first differentiation here is it internal or external pain, right. So external pain puts me basically essentially as a medical or trauma in my mind, right, is my first differentiation. Did I know this before I wrote all this out? Intuitively, I did, but I couldn't.
Never put it on paper.
I never put it on paper. I never could explain it, right? So, I came down to I really differentiate. Am I doing, am I treating a medical problem or treating a traumatic problem? And then when I get into, let's start with the trauma. I look at the patient. Is it a non-shocked trauma patient? Is it a shocked trauma patient, or is it BS trauma? Is it mild trauma, right? So let's start with the non-shocked, which is probably the more common, right? So, yeah, they were in a car accident, they have pain, they're beat up, but they're not trying to die, right?
And you're not talking about an electrical shock patient. You're talking about a shock.
As in physiological shock, right? And that's a fentanyl case in my head, right? With the understanding that I might have to redose, but it's generally from a hemodynamic standpoint, it's safe, right? I'm not going to push them down a rabbit hole if they are bleeding and I just don't recognize it right now or something else is going on. If they're already shocked, then ketamine's my choice, right? So there's that little extra sympathetic bump you get with the ketamine. I'm actually not pushing them down. If their heart rate's 120, 130, and that's making a 78 systolic, and I take away that pain, I'm not as apt to tank that blood pressure, right? So ketamine is kind of my option there. And then for milder BS, I got a herdy ankle, right? Potentially a Toradol or a fentanyl, depending on essentially
how hurt the ankle is.
How herdy, right? How herdy the ankle is. And then from the medical side of things, so kidney stones, flank pain, right? That kind of lives off by itself because we need someplace to put Toradol on my list, right? That's basically the only reason, right?
What if it's left-sided, ripping, tearing, and going down my left leg?
No.
So, right, yeah, the ripping, tearing, of course, puts us into a whole different, and that puts me into one of my other columns here, right? Which is everything else column.
Oh, okay.
I have an everything else column. So the flank pain to kidney stones, probably Dilaudid and Toradol. Likely both, right? I mean,
they work well together.
Most of the time, one of those agents alone is not going to fix all probable kidney stone problems. So both are in my list there. ACS, basically because protocol says so, exclusively fentanyl, right? Mm-hmm. And we know that's well established, the safety profile there. Hence there's no need to put anything else in that list. And then essentially my everything else column, right, is everything else medical. So the non-cardiac chest pain, the belly pains, the back ripping, tearing back pains, is Dilaudid, and I find myself giving more of that. Really, and we were talking about this. You went with the pharmacokinetics and the dynamics of it. Understanding I have to be cautious with that, with renal failure and stuff like that. I usually kind of sway towards it for the longevity, right? I don't necessarily want to have to redose my patients, and when I deliver them to you, and you're working a code, they got belly pain and they get triaged a little bit lower, right? You're working a code, you got a trauma, you got a STEMI. I know they're going to be decently analgesic while they're sitting and waiting. Now, all of that is completely subjective and per case basis, right? And that's not an absolute, but as I wrote it out, that's kind of where my.
I like it. You missed one though.
What's that?
Tetracaine.
Ophthalmia, and that's easy, right? That's non-penetrating eye trauma, right?
Which works great if we recall Dr. Spanner on being maced. If you have a maced patient, Tetracaine would work really good.
Yeah.
Did he said that on his episode?
I'm not sure if it was in person or on the episode.
Well, it just got said now,
It's
so
just got
spot
said.
on.
I
yeah.
will give that to him.
Yeah, hose them out. Hose them out, and a couple of
drops.
Yeah, I drop it.
It did come up either on or off area.
It must have been off. I don't recall it being in the episode.
Because I would remember it.
In the episode. So
what? I guess what does Caleb do?
What's everybody else's
He's
thoughts?
spot on for me. I find myself also having another column in my mind though that says age dependent, and usually over 65 I like to give something more like I don't know, the fentanyl seems to stick out in my mind.
Yeah.
So, but otherwise I think we're on the same wavelength here.
Yeah, I would just come light with the Dilaudid, and then work it up if they need it, right?
And like you said, you're going to talk to 10 people and get 11
11
answers.
different answers, right.
I just, for some reason in my mind, I see age there too.
Yeah, and
Do you favor fentanyl for those cases than Dilaudid?
I do, yeah. I don't know why.
Fair.
What about you?
I'm actually more so for trauma. Just to make mine easy, I would say trauma more of a fentanyl ketamine.
Yep.
Medical, depending on what it is. Usually my front runner is actually fentanyl. I use fentanyl the majority of the time. Kidney stones is probably the only time you'll ever see me use Toradol ever. That's just me. It has a lot of contraindications, so I usually just avoid it. Very successful for kidney stones, so if I'm really headed down that path, that'd be my Toradol column. Dilaudid is probably my most underutilized for me, just because we have a shorter transport time. So for that fentanyl, for that that 15 to 20 minute window, I might have to redose it. But if I'm giving that med in the house, I always think about it. If I'm giving that med in the house or out in the field, move them to the ambulance, and now my transport time, I might have to redose it, but I'm okay with that. I've always done that, so I probably used a lot at the least. It's good for unremitting pain, maybe some type of back pain kind of comes to mind that is not tearing, shearing, almost like you're going down dissection or like that road. No, I wouldn't use that because I'm going to lower their blood pressure, but. I would say fentanyl is probably my front runner, and then ketamine probably comes more into mix for more severe traumas, kind of like you. Toradol, though, I'm very specific. It's in a kidney stone column, and that's it for me. Yeah. That's just it for me. So Dilaudid is at the bottom of my use list. That's just me personally.
So if you have a lot of pain and you want to treat pain in dissection, I would actually go for Dilaudid for the side effect of maybe dropping their blood pressure, because that's really
decrease the bleeding.
Is.
Yeah,
it's decreasing the blood pressure.
I actually have two thoughts about what you said, but since now you've thrown the blood pressure thing in, let's talk about blood pressure and Dilaudid, because it's always been a concern on anything I've ever read, and I've never experienced it practically in use. Understanding I'm 2 milligrams or less in all of my doses, right?
Yes.
Because my box is out at that point. So I've never really gotten into any recallable trouble with it. Maybe it's saying a little bit, but nothing that.
No, nothing you can't recover from.
Not even that.
No,
never.
I think I have that in my head more so for it could cause respiratory depression. I've seen that happen in trauma patients that are shocky, where squads have given it wrong. So I think that's where I just kind of put it on the back burner.
That's not why it's in my trauma.
So that's just I exclude it for trauma. Maybe that's why. I don't know if that's the wrong way to think about it, but I don't know. It's just I know it's a safe play in my head for I go this route. It's not going to affect me at all. I'm not really going to have to deal with any side effects.
But also too, are you dropping blood pressure because you're easing pain? If it's not significant, it might be that you're helping. So,
correct.
Yeah,
That's a possibility. Yeah.
Yeah, because I mean, if somebody's in pain, they're going to be tachycardic. They could be tachypneic. They could definitely have hypertension. And then as soon as you take that away, we get that relaxing point, and then yeah, it could improve it.